My name is Maggie Langins, and I am the Nursing and Midwifery Policy Advisor at the Regional Office for WHO Europe.
Is it working? You can hear me, right? Okay. So my name's Anne Robbins. I'm from UNICEF, and I am a new global health advisor for primary healthcare and health systems. I'm delighted to be co-moderating this session with Maggie. I think it's really exciting and so important to have health workforce discussed in the context of primary healthcare. And we're not so many in the rooms. If you can come towards the front, then we'll be able to communicate much more easily.
The Alma-Ata Conference 45 years ago reaffirmed the WHO's Constitution's definition of health. As Dr. Azopardi Muscat reminded us this morning, it is the state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. While many of the discussions today are focused on the concepts and practice of primary health care, looking at innovation and models, the Alma-Ata Declaration made a further specification, and here I read verbatim. PHC relies at local and referral levels on health workers, including physicians, nurses, midwives, auxiliaries, and community workers as applicable, as well as traditional practitioners as needed, suitably trained socially and technically, to work as a health team and to respond to the expressed health needs of the community. On rereading this and coming off the Aging Summit in Portugal and the World Health Summit in Germany, we find ourselves asking a number of questions. Have we achieved the paradigm shift that Dr. Jan de Messenir spoke of at the previous session, necessary to capacitate and make our workforce resilient, to integrate public health, community structures, and social care into primary health care? Or are our health systems' front lines foundations eroding just as the needs are ballooning? Is the front line of our health systems blossoming and thriving with multidisciplinary network-based services that can cushion and support the growing inequalities that have been worsened by COVID-19, the ensuing recession, the climate change emergency, and the conflicts around the world? Or do we still see too many examples of systems characterized by the lone family doctor or over-specialization marginalizing the principles of community, health, and PHC? Perhaps in our efforts to not leave anyone behind, we have forgotten some key players, our health and care workforce. Have we left them behind? Do we understand the health outcomes of our communities as well as we understand the trends in performance and structures of our health and care workforce? Their health, their well-being, their working conditions. Will it finally be the pandemic and this moment in history that we are gathered here today for to realize we cannot just take this resource for granted, not a single one of them? That is the challenge for our discussion now. And as I invite the panelists and our respondents to the stage, we are going to show a short video. Please come
What a wonderful video. I love videos with happy endings. So just shows how important it is to take care of our health workers. And without our health workers, primary health care doesn't happen. So let us hear from the experts about how we can support primary health workers and especially primary healthcare workers so that we can deliver for all populations around the world. So it's with great pleasure that I will introduce Tomas Zapata, who is our Regional Advisor for Health Workforce and Service Delivery Unit. He is going to talk about the leadership of WHO in a regional framework that can guide us moving forward, especially after a meeting in Bucharest and the regional meeting coming up this coming week. So over to you, Thomas.
Thank you so much, Anna and Maggie. So I think it's after lunchtime, so I hope that we managed not to get sleeping in the presentation. But very quickly, just to give an overview of health workforce in the region, for those who want to see the slides in Russian, please scan the QR code and then you will get access to the Russian slides. So last year we launched the regional report, Health and Care Workforce in Europe, Time to Act. That report presents the main challenges in the region and presents some of the key data and way forward on health workforce. And the report made headlines in most of the newspapers in the region. And it made headlines because health workforce crisis is happening in many of our countries in the European region. That's why it captures so much attention. And one of them in The Guardian was a ticking time bomb, which was the title of our press release, and you will understand later on why it was that way. So some of the results of the report, if we look at the data, in the last 10 years in the region there has been a 10% increase in the density of doctors in the whole region. But when we look specifically at GPs and family doctors, what we see, as Natasha mentioned this morning, that in 17 countries there has been a reduction in the density of GPs and family doctors. So we have more doctors than ever, but we are getting fewer family doctors in quite a few countries. And when we look at the share of family doctors against the total number of physicians, what we see in few countries is also a decline of that proportion. It means that we have fewer family doctors and more doctors working in other sectors in the health system. When we look at nurses, again, we see an increase of 8% of nurses density, but in the eastern part of the region, in few countries, we see a reduction on the nurses density. I would like to tell you what is the situation of nurses in primary health care, but we don't have data at the moment. So that's why it's so important to be able to improve our information systems and capture better data so we get a better understanding. When we look at the production, we see that there has been a 37% increase in the production of doctors in the last 10 years and a 26% increase in the production of nurses. So basically the message here is we have more doctors than ever in the region, and WHO European region is the region with the highest density of health workers in the whole world. So the question here is, why are we having shortages if we have so many doctors and more than ever? And the way we explain this is, one, that we have a high attrition of health workers. And this attrition applies to primary care workers. And the first element contributing to that is the aging of the health workforce. We can see that in 13 countries, more than 40% of the doctors are over 55 years of age. That means that in the next 10 years, more than 40% of the doctors will go on retirement. That's why we are talking about a ticking time bomb and a huge tsunami of retirements in the next 5-10 years in most of the countries. And this is contributing to the crisis. In nursing, we don't have this problem yet because we have a younger population, but if we don't do anything, we'll have the same situation in 10 years' time. The second factor is increased deaths during the COVID pandemic, around 50,000 in the region. It's not a big number comparing with all the health workers, but it has a profound impact in the mental health of the health workers that have seen colleagues working hard during the COVID pandemic and passing away. So it's important to keep that in mind. The third element is migration. After the COVID pandemic, there has been a 27% increase in the migration of doctors globally to the OECD countries, and a 79% increase in the migration of nurses. So this is an important factor of attrition of health workers in many European countries as well, in other countries. And the last factor is the increased resignation because of burnout. We have seen that across different surveys in the region that up to 50% of the doctors and the nurses and other health workers have experienced burnout during the COVID pandemic. This is a huge number that we really need to pay attention and look at the working conditions. So that's on the demand side, on the supply side. On the demand side, what we see is an increase in the demand for services because aging population, chronic conditions, increased demand for services, increased backlogs after the COVID pandemic. So all this is pushing up the demand while we have the attrition pushing down the supply of health workers. And all that is creating the shortages that we have in the system in Europe at the moment. So in order to address this, what we are proposing, and we have been working with the member states, and we work in Bucharest, in the regional meeting in Bucharest, and the Bucharest Declaration is putting forward this framework for action. And this framework for action puts at the center retaining health workers. We need to keep health workers, the existing health workers, in the system. And in order to do that, we need, as a first action, to improve the working conditions. We need to reduce the workload, reduce the number of hours to a right number. We need to provide fair remuneration. So we need to take into account all these things in order to be able to keep those health workers in the system. And of course, as it was mentioned this morning, rural retention is one of the key issues in many of our countries. So we also need to put resources, financial and non-financial incentives, to retain those health workers in primary healthcare areas, in rural areas, which play a critical role. Then we have build supply. We need to think about future needs of health workers and how we train them in those competencies and those skills, including digital health, so that they are fit for purpose in the future. The third pillar is about optimizing performance. If we have limited number of health workers, how we can maximize their work time, how we can bring efficiency, how we can make use of digital health technologies, how we can bring the right skill mix, and in many cases, as we were discussing this morning, is how we expand the scope of practice of nurses, how they can play a more active role, and they are paid, and they are trained, and they are supported in order to do that. And the last two pillars are the enablers. One is planning. We need to plan in 10, 15 years' time what will be the requirements of health workers so that we can start acting now, so that we don't have this tsunami on many factors again. And the last one is about investing. We need to invest more in order to do this, and we need to invest more smartly in order to be able to implement this. And the last, this Thursday, during the regional committee, all member states, and led by Romania, and the Minister of Health is here, Dr. Rafil, and I want to thank him, are going to put a resolution forward to be discussed and endorsed so that we can really strengthen the health workforce in the European region. And at the end of the day, my key message is let's really support and improve the working conditions of health workers so that they can be happy, they can have time to smile, as the nurse from Norway was telling us this time, so they can really perform up to their abilities so that everyone can benefit, including the patients. Thank you so much.
Wow, thank you so much, Thomas. You've really grabbed our attention. So we have a ticking time bomb. Remember, ticking time bomb because of age, death, burnout, migration. But don't worry, because the framework tells you what to do. So you've motivated us all. We're going to read it. We're going to take it home. We're going to follow it. And we really hope that you get it approved in the next few days. So now we're going to turn to Dr. Bouzouita, who is the Director General of the Ministry of Health of Tunisia. And he is going to talk about family medicine and how it's central to primary health care, and perhaps also help us to understand how we retain those doctors working in family medicine. Over to you, Doctor. Thank you so much.
Thank you very much. First, I want to thank you to invite me to share with you the experience of Tunisia today. I want to talk to you about our strategy in Tunisia, our policy. Since independence in 1956, the government gave a big place to the primary health sector, and they developed many structures. Actually, we have about 2,200 structures in primary health care. We have 4 medical schools, and we have one direction in the ministry which leads all these units of primary health care. We develop actually many national programs like vaccination, eradication of polio, eradication of trachoma, prevention and treatment of hypertension and diabetes, reduced maternal mortality, and etc. And in 2019, the government signed the national health policy, which is very important to have one vision in our country. And the big challenge actually is the transition to family medicine. To provide some historical context, the trajectory of family medicine in Tunisia was discussed in 2006 when it was initially proposed as specialty during discussion about medical studies from the reform. However, the decree was published in 2011. The government definitive recognition of family medicine as distinct medical specialty came through a decree in 2019. The pivot step led to establishment of the College of Family Medicine, primarily entrusted with delivering well-structured education, proposing comprehensive training program, and issuing the necessary certification for practice. The regional professional diploma in family medicine has been important transition progress, aiming to enhance the capacity of general practitioners to provide high-quality primary health care services. Another way advancements have made in establishment of the program. The inaugural cohort, initiated in June 2023, was support from WHO. Encompassed 60 participants selected based on equitable representation from various regions, medical schools, rural and urban area, and both private and public sectors. Special attention was given to include doctors situated far from medical schools to ensure they have equitable access to necessary skills. The identification of training centers currently in progress is being overseen by the dean of 4 medical schools across different regions to ensure, and we are accredited with our accreditation body, our centers. Actually, we have other challenges. I just say the name. We have to develop more unit of oral vocal unit to treat dental, unit of habilitation to put a digital system in our primary health care, to develop and to change legislation in mental health. And the last one, and not the least, and I consider it's more important, is to communicate to population the real place of primary health care in the system and to encourage all the people to consult in primary health sector system. Thank you very much for your listening, and I wish that this shared experience will enhance more discussion in this planning.
Thank you very much, Dr. Bouzouita. Let's give him a round of applause. And thank you so much for talking today, but also for being a champion for family medicine. It's taken 13 years to go from the idea to a degree. So phenomenal work. Thank you so much. Over to Maggie.
Dr. Daulet Aldyngurov, the Director of Department of Science and Human Resources at the Ministry of Health of Kazakhstan. I'd like to invite you to share with us some of the progress with supporting the modernization of nursing education. As we know, it is not just family doctors, but 90% of our health system's contacts are with nurses who have then the potential to coordinate with other health workers and make sure the care is around the patient. So if you could please share with us, Dr. Daulet, what has been happening in Kazakhstan.
Спасибо большое, Мэгги. Я хотел бы коротко рассказать именно тот опыт, который произошел вот за последние 15 лет в Казахстане именно по модернизации образования, потому что мы понимали, что еще 15 лет назад мы готовили медицинских сестер всего 2 года, и они были средним медицинским персоналом. Также высшее образование претерпело реформы, потому что в то время обучалось 6+1, это бакалавриат и интернатура. Соответственно, на сегодняшний день с поддержкой всех наших партнеров из-за рубежа, это большинство университетов Европы, европейских наших партнеров, которые помогли реализовать и перестроить систему подготовки медицинских кадров в целом. Ну, на сегодняшний день мы интегрировались практически в образовательное пространство. У нас сегодня есть бакалавриат, магистратура, докторантура, а по медицинским специальностям у нас интернатура и полноценная резидентура. А что касается сестринского дела, то мы уже понимаем, что медицинские сестры – это не просто средние медицинские работники, мы их уже не должны так называть, и они в будущем должны стать отдельной службой, которая будет иметь свой отдельный функционал. И, соответственно, мы перешли к тому, что готовим на сегодняшний день медицинских сестер профессионального уровня. Также у нас есть прикладной уровень, то есть академический бакалавриат, а также высшее образование. И буквально последние проекты с Европой, с университетами Европы, мы сумели внедрить магистратуру и докторантуру, уже есть первые выпуски. Соответственно, мы очень сильно надеемся, что новая генерация медицинских сестер экспертного уровня в будущем подхватит и реализует основной принцип, это медицинская сестра преподает только медицинская сестра. То есть никак не иначе, на сегодняшний день у нас не хватает преподавателей, но мы с помощью наших партнеров из Европы, с университетов, мы на сегодняшний день стараемся воспитать новое поколение медицинских сестер и надеемся в будущем медицинские сестры, как сегодня уже говорилось про самолет, в котором крылья – это основная основа взлета, поэтому в ПМСП основную роль будет играть именно медицинские сестры. Но у нас есть опыт, когда у нас есть фельдшера, которые тоже готовятся на уровне среднего в медицинских колледжах, соответственно, у нас и акушерки, мы этот опыт не оставляем, и этот опыт у нас тоже сохраняется. То есть у нас на сегодняшний день вся линейка реорганизована, и мы считаем, что это все достигнуто с помощью поддержки Всемирной организации, с помощью поддержки наших партнеров из Европы, стратегических партнеров и университетов Европы. Поэтому, безусловно, реформа образования – это одно, но есть еще проблема со стороны практического здравоохранения, потому что нам следует в будущем четко разделить функционал, то есть уровня профессионального, уровня академического, уровня высшего, магистратуры и докторантуры. Соответственно, где использовать квалификацию этих специалистов – очень сложный вопрос, и именно касается практического здравоохранения, потому что мы еще практическое здравоохранение не полностью принимает этих специалистов, и предстоит огромная работа. В целом, вот такие реформы произошли, и мы бы хотели бы дальше развиваться и иметь партнеров, и дальше улучшать ситуацию вот в медицинском образовании, которая напрямую связана с практическим здравоохранением и медицинскими услугами. Спасибо большое.
Thank you, Dr. Aldyngurov, and that really echoes the message we heard today, that the work of caregiving is actually complex and requires science behind it, and we cannot forget that the other health workers around our family doctors also need their education to be strengthened and the scientific tradition developed for them to improve healthcare for our patients. The next speaker is Dr. Zlata Mimidovic, and he is the coordinator for reforms in primary healthcare in North Macedonia. And Dr. Mimidovic, you've been quite busy in North Macedonia organizing multidisciplinary teams and really trying to shift the paradigm in primary healthcare. I wonder if you can share with us some of the reflections of what has been important to sustain that.
Thank you very much, Maggie. As well as you said, North Macedonia, and I can remember it clearly, 5 years ago here in Astana, I actually on one of sessions like this introduced the use of the model of multidisciplinary teams within our country. And we were very proud because at that time there were not so many countries that were introducing the multidisciplinary teams approach in delivering care to the citizens. So 5 years after that, what we have been trying to focus on was actually trying to optimize performance of the multidisciplinary teams, and that was quite a challenge, since we knew that there was a lot of workload at the existing healthcare workers and social workers as well in delivering those kind of care among the citizens in North Macedonia. So what we have been focused is how to be engaged more in providing training and skills for the healthcare workers to be better prepared and that can much easily challenge or tackle the challenges that are among the population where they were delivering services in multidisciplinary teams. And in August 2021, after I can say almost 6 years of detailed analysis, preparement, and taking steps properly to implement the reform in primary healthcare, we managed finally to start and to implement the transformation, as we call it, of the health system by reforming primary healthcare. And by that transformation, we meant that we will be actually doing task sharing between healthcare workers and social workers so that they can deliver services better and according to the certain references, clinical pathways that were actually meant for certain professionals that were engaged in delivering those kind of services in multidisciplinary teams. So the reform, as I said, started being implemented in August 2023. And in the first couple of months, since we had it, we can already see the results of how the healthcare workers are doing. How can they actually be well producing or giving healthcare to the citizens. So that is very much important as a starting point to see if we are moving in the right direction. And I can proudly say that yes, I think that we are going there because, as I said, taking away the unnecessary administrative burden from the shoulders of the nurses or taking away some of that administrative burden from the doctors, also getting them more time to be engaged with other parts of the multidisciplinary teams was very much important in delivering right healthcare services. As I said, this is only the beginning. We will continue to evaluate how the reform is going on, and I hope that even sooner, not in 5 years, when we will do another commemoration of Astana Declaration, we will have something to be proud of and share it with you.
Thank you, Dr. Mehmedovic, and I think this really conveys the importance of trusting the process. Let's give him a round of applause, getting too excited to comment, and it's been really exciting to watch the developments in North Macedonia. Thank you for that.
So it's my great pleasure to introduce to you Dr. Yusufi, who is the head of Medical and Pharmaceutical Education and Personnel Policy and Science Division of the Ministry of Health and Social Protection in Tajikistan. So Dr. Yusufi, I know that you can offer a lot to this discussion. We heard from Thomas how important data is in workforce planning. We would love to hear from you your advice on how to use that and learn from your experience. Thank you.
Спасибо большое за предоставленную возможность поделиться опытом Таджикистана по развитию кадровых ресурсов в системе здравоохранения. Общеизвестно, что качество медицинских услуг зависит от наличия соответствующего количества медработников. Естественно, если мы хотим улучшить качество медицинских услуг, целесообразно или в начале, или параллельно провести реформу медицинского образования и иметь разработанную программу по подготовке и развитию кадровых ресурсов. Когда в Таджикистане мы начали реформу первичной медико-санитарной помощи в связи с переходом на семейную медицину, нам надо было подготовить соответствующее количество семейных врачей и семейных медсестер. И вначале мы их подготовили, семейных врачей подготовили на основе 6 и 9-месячных курсов из числа, путем переспециализации из числа тех узких врачей, которые работали в первичке, а потом на этапе двухгодичной клинической ординатуры. И потом мы создали республиканский учебный клинический центр и приняли программу по развитию семейной медицины. На данный момент учебный клинический центр имеет 4 областных центра и 12 межрайонных центров. Ну, естественно, как и в других странах, в Таджикистане тоже осуществляется нехватка врачей, но анализ показывает, что из года в год показатель укомплектованности улучшается, и в данный момент для врачей она составляет 91%, а для медсестер 98%. Основной проблемой в области кадровых ресурсов является географический дисбаланс врачей и медсестер. Улучшение ситуации в этой области связано с применением ряда вмешательств. То есть это выделение президентских квот и определенных льгот для лиц, которые проживают в районах с низкой обеспеченностью врачей, а также создание целевых групп по подготовке медсестер в отдаленных районах и сельских местностях. Однако пандемия COVID-19 показала слабые места в системе здравоохранения, касающиеся набора, удержания и защиты медработников. Таким образом, возник необходимость в пересмотре стратегии качества управления и планирования кадровых ресурсов. В связи с этим, с поддержкой ЕРБ ВОЗ мы провели комплексный анализ рынка труда в сфере здравоохранения Таджикистана. Проведенный анализ показал, что за последние 8 лет рост врачей увеличился на 20%, а медсестер на 41%. Плотность врачей увеличилась на 2%, а медсестер на 22%. При этом плотность семейных врачей снизилась на 21%, а плотность семейных медсестер увеличилась на 71%. За последние 8 лет ситуация географический дисбаланс, то есть неравномерное распределение, до сих пор сохраняется. Доля врачей-женщин среди врачей составляет 39%, что ниже, чем по европейскому региону, где оно составляет 48%. 78 врачей моложе 50 лет, и это говорит о том, что в стране нет проблемы стареющих врачей. Гендерный и возрастной профиль тоже отличаются в регионах. Например, если на юге страны доля женщин ниже, чем на севере и в центре страны, то тогда доля врачей моложе 40 лет на севере ниже, чем на юге и в центре страны. Число выпускников из года в год тоже увеличивается. Число выпускников женщин, врачей на этот период увеличилось на 55%, а среди мужчин на 100%. Конечно, эти данные очень важны, и в будущем мы планируем совместно с поддержкой ЕРБ ВОЗ разработать стратегическую дорожную карту по развитию кадровых ресурсов в Таджикистане, и полученные данные будут принимать за основу для решения существующих проблем по снижению плотности врачей, снижению оттока медицинских работников за рубежом, а также улучшение качества подготовки врачей и семейных медсестер и расширение сферы деятельности медсестер, а также разработка мер по мотивации врачей.
Thank you.
Thank you very much, Dr. Yusufi, for sharing how we can use administrative and survey data to plan our workforce. That was very informative. Thank you.
I'd now like to turn to you, Taru Koivisto. You are the Director General of the Department for Communities and Functional Capacity at the Ministry of Social Affairs and Health in Finland. And we have heard from our previous speakers about the ways in which they're preparing the health workforce to respond in primary care. But Finland has embarked on a very interesting program to support the health workforce with working conditions and address working conditions. As a country that is so large, with health workers working in rural areas as well as urban areas, can you tell us about how you reach all of those? Can you tell us more about the program, I think, first, and then how you ensure that all health workforce is included?
Oh, no, it's on. Yeah, thank you so much for this opportunity to share the views of Finland and experiences. So, first of all, I want to start by saying that we are all in the same boat.
Yeah.
So that I think the challenges and problems are similar in all countries around the world. So we have a lack of healthcare personnel. And that's something which is, we can't solve it by moving people from country to country. It's not a solution for the problem. We have to think it by ourselves what should be done. And for Finland, the challenges especially are aging of society, the increasing service needs, and people are expecting different kind of services, different kind of approach. And of course, all this makes it more difficult to provide the services. So, and COVID-19 has not made it easier. So there are a lot of pressures, but what we have been thinking in Finland is that we need different measures, different kind of approaches. We need short-term measures and long-term measures so that we could find the solution from there. So we have in Finland much personnel just now, as you could see from the statistics, but not enough compared to the needs. And in Finland, especially, we have had this personnel structure such that we have a lot of nurses compared to the doctors. And nurses have always had a very strong role, for example, in primary healthcare, nurses and public health nurses. And we have had this problem for some time. It's concerning all the professional groups. It's not just doctors or nurses, but all the others also, dentists, physical therapists, everyone. So we are really lacking them. And it's not only on some parts of Finland, for example, rural areas, it's all over the country. So it seems to be more about how attractive the working places are. So that's something which it's more important than the place where the workplace is. It seems such. So we have been trying to find the solutions for some years already now. The previous government had some program already in place to find the ways how to ensure that we have sufficient personnel available. But this government, which is just got in the spring, is now launching a new program on this. It's based on the work we have done already, and actually it will be launched in a couple of weeks in November this year. And it's the whole government behind this. We have to do something and find practical solutions. So it's based on the work we already have done, as I said. We have done a strategic roadmap which will be the basis for this activity, and it's practical. So it was published already in February this year, and now we are continuing the next 4 years based on all that. And I want to emphasize that the role of WHO have been important here. So we have followed the developed work in Europe and used the framework which is now going to be adopted rather soon as a basis. And actually the new program will be structured around the titles of this framework. So it has been useful. As I said already in the previous session, WHO has been a very important support for us always in the history. So about the program. So it contains, I take the things which I think are the most important. Of course, we need to increase numbers of training, and we need to create the contents or develop the content so that these are what is needed now in the workplaces. And then also the structures of education will be looked at. If there's something needed to change, that it's possible to have continued education, etc. But practical issues which we already started and will be implemented is reduction of tasks, so that the professionals do what they are educated to do, and what is most important, so that we are looking at what are the tasks which are not anymore necessary. For example, different kind of formulas or different kinds of papers, etc. And then also how we could also use more support personnel, assistant personnel, more and more, so that the professionals can do what they are educated to do, and especially take care of the patients. So that's about the reduction of tasks. Then the clarification of division of labor. So actually it's about the support personnel, of course, what they can do, but also what are the tasks of doctors, what are the tasks of nurses, and what are the tasks of other healthcare professionals or social care professionals. So that because of that, the multi-professional teams in Finland, in primary care, healthcare especially, are very important, so that it's easy to look who is doing what and have good coordination of activities. And we are going to look at that through very, very carefully. And as I said, nurses are well educated in Finland, and they have more advanced roles, more and more. So it's the role of the nurses will be essential, even though we have a lack of nurses as well. So, and then next area is workability, the working conditions, which we, as I said, how people find the workplace, if it's attractive. It's also concerning very much about what kind of circumstances there are, what kind of support activities, etc. But especially I want to emphasize one thing, it's leadership. That's something which is very important, because it's the leadership which creates the possibilities for people to implement their abilities and use their knowledge and experience, and also coordinate the cooperation between the different professionals. And that's something which, especially in Finland, is now a big challenge in care for the elderly. Because care for elderly is now almost in a crisis in Finland. It's not anymore so attractive it used to be, and it's difficult to get their personnel. And there, especially, the response is that the leadership is lost there. And that's something which we have to do something. It's not so much about the other parts of social and healthcare services, but especially the care for the elderly. And then, at the same time, in Finland, we are going through a big reform of social and healthcare services. It can be an opportunity to create better conditions for work and better way of organizing services, but at the same time, it can be a challenge as well. So we don't yet see, because it has started in the beginning of this year, so it takes some time. But what I want to, these are the titles of the program, but I want to take up some other issues as well, if it's still time to do it. Yeah, just shortly. So we need to cooperate very closely with different other ministries, for example. Ministry of Education is a key, because they regulate and they are responsible for education. But also Ministry of Labor, for example, what kind of working conditions there are, and other ministries as well. And then another area is data, knowledge base. We need to also develop that. We need to know the situation. We need to know what are the trends, and we need to know what are the problems. And at the same time, I think the last one is how we make social and healthcare attractive place to work. That's something which it's the biggest challenge. How so that people want to become professionals there and want to work there. So I think that's something which we need to do. So thank you.
Thank you, Taru. There's a lot in there. There are some international frameworks that are maybe not as old as the Alma-Ata Declaration, but there is a framework available for occupational health that WHO launched, I believe it was in the 80s. But also, you've really highlighted how important it is to provide primary healthcare centers the flexibility to coordinate themselves, to prioritize and assess at that level their well-being and their working conditions. And I know that in our region, a lot of countries are looking for examples of how to do this, that a sort of assessment is not as straightforward, or we don't have templates for that. So I do encourage this group, all of you, to network and connect with each other on the areas that you have heard from all of our speakers that might be areas you'd like to develop. Now, our 5 panelists have been listened to by 3 very special respondents before we give the floor to some discussion. And the first person I'd like to give the floor to is Rukiye Akay, who is the Director of Internal Affairs from Turkey of the European Early Career and Nursing Student Organization. So Rukiye, what have you been listening? What would you like to say?
Is it working? Is it? Yeah. Good afternoon, esteemed colleagues. Many of my fellow students and early career nurses had choices to join this profession or not. At this point in history, with the pandemic, climate change emergencies, and wars in the region, that choice was an especially careful one. My choice was between biomedical engineering and nursing. But because I wanted to work with people and bring people better health, I chose nursing. As a nursing student who has dreams and hopes to be a nurse in primary healthcare, I truly hope that we will all see the benefits of the discussions on and reflections discussed here in Astana. My biggest dream for primary healthcare is to work with digital solutions for nursing care so that this profession can adjust more smoothly with the changing times and technologies and meet the growing health needs. I believe that the smart use of digital technologies in nursing care will have positive outcomes both on health workers and their patients. I believe we can be smarter in using data about our communities so we can ensure this community better health. I read and learned about such solutions. I have ideas, and soon I will have more ideas. In most instances, the solutions can help primary health care from patients' perspective. But with time, I also want to develop innovation can reduce health workers' work and give them better working conditions and change the care that patients receive. With better working conditions, I believe that nurses will have more capacity to do what they do best. Get to know the community that they are working for. It might be a family, it might be a city population, or it might be a world. And if a nurse knows the community, they can foresee the upcoming risks. With time, I believe that innovative nurses can contribute to healthier communities. But my question to you is, will there be a place for nurses like me?
Thank you so much for those reflections. And just before we turn to the audience to learn from all your experience, I'd like to introduce you to a frontline nurse, Ariel Oribo, who's going to talk about primary health care and what we can learn about how to meet the needs of the older demographic. Thank you.
Yeah, this is really exciting for me. I liked so much of what you were saying, Taru, because it's something that's very valuable for all of us to listen to. I went to Finland, actually, and observed the healthcare, and I think that there's a lot of examples there to follow. But I'm thinking about how to recruit and how to retain, because working as a nurse in primary healthcare, specifically with elderly, we're having great difficulties. And I live in a city that is very close to our capital. And you would think, and it also has a university in that city, and you would think that it would be easy to recruit nurses to primary healthcare, but it's not. And we're struggling a lot to get enough nurses for our healthcare. And I think that several people have said here that we need to make the primary healthcare attractive, because right now the hospitals are kind of like sucking out from the university all the nurses. And we're having difficulties attracting them to primary healthcare. And what we're seeing in primary healthcare, a reason, you know, they always have to come out to do their practicum or the practical training, and they see that this is a really hard place to work. Not only are nurses and nursing students observing that the job is mentally exhausting, it's physically exhausting, and it's emotionally exhausting. Who wants to go start and work in that kind of environment? So I think that if we're going to be recruiting nurses, we have to make it attractive, make the workplace or the day easier to get through, to prevent this burnout, to prevent that people are getting so tired. And also, it's interesting that if you give benefits to nurses, that also helps out, but it demands investing in these nurses. We've seen several examples that if you increase the pay of nurses, and I know we're probably not supposed to talk about money, but actually, more nurses take extra shifts and they're willing to stretch themselves a little bit more. But then, on the other hand, it could make them more tired, so we have to have a good balance there. I think that another issue that's very difficult for primary healthcare is that there's a lack of possibilities for further education. Not possibilities per se, but they're not supported by the workplace. There's not a system in place. The only one that is really in place all the way from, in Norway anyway, from the government and down, is nurse practitioner. Because it's so new, then they've been given financial aid to allow nurses to take this education. But then when they're done with that education, there aren't any jobs for them because they cost more. So we have this issue of we need better training, because that also attracts nurses. I want to be at a job where I'm not working by myself as a nurse, where I have lots of colleagues that are interested in our profession and that have a good foundation of professional knowledge. And I also wanted the opportunity to learn more about my profession to be able to do a better job. So this has to be made available. Let's see here.
Abil,
Yeah,
I think you've
that's fine.
already challenged us
sorry.
enough with quite a long list, and I would like to turn to the audience, but as our last respondent, I'd like to ask Corinne Hinlupin from VEMOS, which is a Brussels-based organization supporting research and advocacy for medical rural deserts and migration of the workforce. So you've been listening, and we've been talking about how to prepare this workforce, how to support this workforce. What is the research showing about medical deserts and the realities in rural health areas?
Yes, thank you, Maggie, and thank you for the rich interventions also by the panelists. I've heard so many things also from my fellow reflectors, so to speak, that resonate a lot with what we've done in our project on medical deserts. Of course, there is the challenge of supporting, recruiting, retaining health and care providers in the rural and remote areas, and it's important to provide adequate support to the people working there. For example, in clinical networks, for second opinions, expert inputs, as well as peer support. It's also very important to develop specific rural health curricula, because we've heard primary health care is complex, but primary health care in rural areas is even more complex. So you need a specific curriculum and specific and systematic continuous professional education opportunities, and not just for the general practitioners, but also for the nurses and the midwives and other professions. And focus on, or try to do your best to train and educate people who hail from the rural settings, because evidence shows that that increases engagement and retention. And for motivating the people and making the jobs more attractive, we've heard a lot about that from the different panelists. Combinations of interventions are almost always necessary, not just financial, but also, well, I mentioned the support networks and the continuous professional education, for example. Working in multi-professional teams is another thing that I would like to highlight. We've heard a lot about that. Also the need the need for flexibility to share tasks. I think you were the one also who used that word, task sharing, not specifically task shifting. That's also important in the rural and remote areas, and not only between the health professionals, but but also between the health and the social sectors, and with the community care and informal care and support networks. Because very often in rural and remote areas, these support networks exist. People have these in place. They are used to having them in place actually and to function like that. And the challenge is to leverage these networks to the advantage of the formal health care. And we have found in our project that the sense of ownership of rural and remote communities is very big for this kind of challenges that we have of medical desertification and the scarcity of human resources for health. Well, and about multi-professional teams, it's also very challenging. We've heard that also in the plenary this morning. Alignment of them can be very difficult because of the different funding streams, for example, or the different lines of accountability. And that has to be tackled upstream, actually. So whatever solutions you think of at the local level, they need to be supported at national level. Think about the legislative and normative frameworks that need to be in place to make the local level solutions work. And last but not least, what I would like to highlight also, that working in multi-professional teams, you need to be aware of the different professions in those teams, because not all the professional cadres are adequately represented in the policy deliberations and decisions. For instance, the women and people from ethnic or racial backgrounds, they tend to work in the lower qualified professions and are underrepresented or marginalized in the traditionally very hierarchic policy decision making. And this is about trust again, and this morning also the word maturity was mentioned, the maturity of the stakeholders. You have to invest in the maturity of the stakeholders so that they can actually participate in the policy making. And as a moderator, so to speak, of such interventions, you need to mitigate the existing power imbalances and be very, very aware of making everyone heard.
Yeah.
I'll leave it at that. Thank you.
Thank you, and I think that's a nice way to end, to remind us that we don't want to perpetuate the inequalities in our society that are actually growing since the pandemic and since, in this time of economic recession with our health workforce. So that actually as we strengthen this health workforce to be empowered, to be leaders, to be multidisciplinary, to be reflective of the communities that they serve, we can also in a way alleviate the inequality that exists in society by seeing our society reflected in these health professionals and all of them, and not leave anyone behind. So because we started 5 minutes late, we actually still have 5 minutes, and I would like to encourage anyone who would like to raise a question, maybe share a resource that they have found useful. So we have a speaker there who's got the microphone, and then we'll need a microphone on the other side of the room, please. And then we'll go here.
So thank you very much, colleagues. My name is Adam Ogaleski. I represent Public Service International and European part of this European Public Service Unions. Maybe for information, we represent healthcare workers from Iceland to Russia and Kazakhstan and Vladivostok. I last week met our colleagues in the healthcare unions of Kazakhstan at the conference, and the healthcare unions celebrate 100 years anniversary. I just wanted to mention here what I agree with the panelists, but I think it's important in terms of the strengthen the participation of the healthcare workforce. You talk here about empowering them, but we know the legal rules of empowering, that it's social dialogue, that's the trade union rights, that's the collective bargaining. And I'm talking here about that only to highlight occupational health and safety. Yeah. And we know that during the pandemic, and because before the pandemic, we have a mental health of the workforce was decreasing, because there was a lot of patients, there was a lot of demands. And I think mental health here is crucial in order to improve working conditions. Another topic which is important for all of us here is the violence. We see across the healthcare sectors from Western Europe to Central Asia and Southern Europe increased violence against the healthcare professionals. Those include not only doctors, not only nurses, but healthcare assistants, ambulance workers, paramedics. And I think here it's very important for us to work together with the NGOs, with trade unions, employer organizations, but also as well with international labor organizations, in order to ensure that all of the partners are included to make this profession very attractive. And the colleagues were saying, the young nurse saying that, it's very difficult to become a nurse. And this is what we hear. This is what we hear from our workers, even across Norway, that this occupation is not any longer attractive. And we need to ensure that this is an attractive occupation for all of us, because without the healthcare workers, we won't have primary healthcare, we won't have secondary healthcare. We need to support healthcare workers. Thank you very much.
Thank you very much. Can I just have the microphone here, and then we have another gentleman on the side. No, sorry, we had a previous over there after, and then we can come back to you, Ibrahim. Go ahead.
Yeah, I'm Dr. Vijayaswara from Sri Lanka. I'm working in the Ministry of Health. I would like to say a few words about the health workers and losing of health workers. I think presenter said several reasons why lack of medical professions and the health workers. And he highlighted several things. One thing is that I'm not much agreed, and he said about some health workers died due to the COVID-19. In Sri Lanka, my experience, there are 25,000 medical doctors in Sri Lanka. Out of 25,000, they died only 3 doctors. And nurses, of course, less than 5 nurses died due to COVID. But still, we are having a problem with the health workforce. That is because there are skill migration. Skill migration, that is a brain drain, that is a main issue. I think internationally we should have some kind of decisions. We have to take some decision to prevent or to overcome this problem. I can suggest 2 things. One thing is that each and every country having the responsibility to train the medical profession, that means healthcare workers. They have to invest to build the health workforce. In Sri Lanka, for the build of one nurse, we have to spend minimum of 4 years. For the doctors, we have to spend at least 7 to 8 years to build the doctor. For those health workforce, totally free of charge. Even medical profession, medical specialist, we have to spend nearly over 10 years for make the medical consultant. Whole 10 years, we have to pay them, as well as we have to spend for their training, including foreign training. But there are some reasons people are migrating. One thing is that there are some pulling factors in those countries. Other thing is, some other countries, there are some pushing factors. Yeah. There are pushing factors. They are giving some developed countries, they are giving that they pay PR and better salaries and some accommodations. There are that pulling factors. There are some pushing factors. So I know that the financial crisis and other things, they can't pay that better salary and taxes and things and other facilities. There are problems. So that we should have some kind of ethics when they are taking the healthcare workforce to other countries. At least people who are taking will say country A, getting the people from the country B, that at least country A should pay some amount of that fund to train the health workforce. Otherwise, that will be a big issue in future. Some countries that developing and underdeveloped countries, that will be a big issue. Or otherwise, another suggestion, developed countries, they can invest, developing countries and other countries, to develop healthcare workforce, and after that they can take back to their countries. Those are my suggestions. Otherwise, the primary healthcare system and other healthcare services will be in the big issue in the future. Thank you.
Thank you. Anne?
Well, just going to invite the other questions, and then maybe we can answer them all together. So this gentleman here.
Hello, my name is Tural. I'm working for WHO Azerbaijan. First of all, I would like to congratulate Maggie. It's a great panel, very colorful, and it's good to hear the insights from different stakeholders. My question and comment is about shortage of staff. The excellent presentation by Thomas. It's a huge issue globally in many countries, and the bigger issue is shortage of staff in rural areas because it affects people's health and access to the essential services. And I was surprised that last month in September, I learned that there's an organization called General Practitioners at the Deep End in the UK, in Ireland, where general practitioners work in with the most deprived populations, which means that it's a huge problem. And one of the messages I heard and I was touched by was that we call it hard to reach population when actually we mean easy to ignore. Like politically it's easy to ignore. My question is, we acknowledge that shortage of staff, especially in primary health care in rural areas, is a huge global problem. Is there a global initiative to bring countries together and work together on the solutions? Because there are solutions and there are success stories like in Finland. Thank you.
One last question, I think.
This is the last question. We need to wrap up.
Okay, good afternoon, everybody. Ibrahim Durak, again, WHO Azerbaijan. We have very nice action framework with several pillars and then 7 years. And I'm in the supply side again. So Thomas summarized 3 issues: modernizing medical education, the first. The second thing is the continuous professional development. And the third is digital health competencies. So we have several evidence, and the HQ published a new evidence regarding some important elements. What we know at the moment in terms of modernizing medical education, if we train students in the primary healthcare settings in the community, it's tend to work in the primary healthcare settings. At least 3 of the panelists, including our nurse students, talking about the education side, and then long run, the resilience, sustainability in that perspective, I believe. My question is, how we can start applying those 3 actions collaboratively as a community of learner and practice?
And I think the best person to start answering for us is Thomas. If you could reflect.
Yeah, maybe for me, yes, very quickly on Tural. I think WHO updated the global guidelines on recruiting and retaining health workers in rural areas in 2020, and I think that's a very good compilation of evidence of effective policy interventions, and the key messages, I think, is what Corinne was mentioning. It's not a one single intervention, it's a combination of coordinated interventions, and I think it's very important that we need to stress the importance of measuring the interventions and measuring the impact of the policy intervention.
And I also think that we have a few other documents like the Global Code on ethical recruitment and retention of the health and care workforce that I think we need to stand by. But I also think that the framework that Thomas presented at the beginning is really at the core of making our workforce attractive so that so those push factors are not as strong, and that every country has a responsibility to engage in securing its workforce and no longer just looking at it as, no longer looking at the workforce as what it delivers, but how it's doing and how its working conditions are in place, how it's building trust with other health professionals, communicating with the population, and how their mental health is doing. So I think...
I just wanted to add also, as we're talking about rural recruitment and retention, I just wanted to give a mention for the community health workers and the community health volunteers, and how important that the health workers in rural areas give them adequate support and training and supervision, and that they are part of the entire system with a referral network and good clinicians behind them. they are easily, well, not easily, but they are motivated and able to reach areas that others can't reach. So just to mention, thank you.
So thank you, everyone. I think we're going to wrap up now. Thank you to all of our speakers for sharing their experiences so honestly and frankly with us, and to our respondents. In so many respects, the Alma-Ata Declaration was ahead of its time, with the concepts it contains remaining as valid today as they were then. Health and care workers, then as now, were at the heart of PHC approach, but let us not miss this moment to make every health and care worker count and really leave no one behind. Thank you.